Happy Tuesday to everyone and welcome. Thank you for joining us to start your week. My name is Ryan Googe, and I am the Executive Director of the Partnership to Advance Cardiovascular Health, which we call PATCH for short. I'm here on the East Coast, but we're excited to be on the West Coast, at least virtually today. I'm just imagining myself on a sunny California beach tonight. I want to thank, first of all, Amgen for sponsoring tonight's webinar. PATCH is a coalition of a number of doctor, nurse, and patient organizations that work for better healthcare for people living with heart disease. You can see on this slide the many organizations that we collaborate with. PATCH's mission is really about helping people. We want to make sure that anyone who has had a heart attack or stroke, or anyone who is at risk for having a heart attack or stroke, can get the care they need to live a long, productive life. We at PATCH have the opportunity to work with a lot of amazing clinicians and patients who are remarkable advocates. Patients who have persevered through trying times, and clinicians who are frankly the leading lights in heart medicine. Some of those advocates are here with us today to have a heart-to-heart with you. Some questions that we hope to answer tonight. How do you do life once you've had a serious event like a heart attack or stroke? How do you manage risk if you know you could have a heart attack or stroke? Is cardiovascular disease preventable? And what are best practices for keeping your heart healthy? To help us answer some of those questions and any other questions that you might have, we have a number of guest interviews. Our first will be with Kim Newlin. Kim is a cardiovascular clinical nurse specialist and an adult nurse practitioner at Sutter-Roseville Medical Center in Roseville, California. She's served as the president of the local Preventive Cardiovascular Nurses Association chapter as a chapter leader for over 10 years, has participated in several committees and helped develop PCNA's cholesterol brochure and the physical activity section of the Heart Healthy Toolbox. Kim is also the immediate past president of the Preventive Cardiovascular Nurses Association nationally. Following Kim will be two fellow Californians and patient advocates living with heart disease, Vicki and Lisa. I want to note that, just a programming note, that everyone who's watching live should feel free to ask questions in the Q&A box you'll see just below. We'll do our best to incorporate the questions in our discussions. So with that, I want to thank you for joining us again and invite Kim to join me on screen. Hi, Kim. How are you?
Hello. Great. How are you doing?
Great. It's always great to work with you, Kim. So thanks for taking some time to talk about heart disease tonight. As you know, this webinar is really a source of information for people who have either had a heart attack or stroke or know that they're at risk for one. And before we get through some of the questions about heart disease specifically, you are a heart nurse, a cardiovascular nurse, and I wanted to ask you, for those that may not be familiar, what does a preventive cardiovascular nurse and where does the cardiovascular nurse kind of fit in the care team? And I guess it's kind of your 30 seconds to a minute to talk about how awesome cardiovascular nurses are. So can you give us just kind of some idea of where a patient would come in contact with a cardiovascular nurse throughout their kind of journey as being a patient?
Absolutely. So first of all, thank you, Ryan. I always enjoy my time with PATCH, and thank you for the work you guys are doing to advocate for better care for our cardiovascular patients. I feel like we're the warm-up act for the important act following us with patient advocates. So I'm glad Vicki and Lisa will wrap up our conversation tonight. I'm always happy to shamelessly plug the role of the nurse, and you would encounter a nurse pretty much anywhere across the continuum of care, whether in the prevention stage, in a medical office, or maybe in an exercise program. For sure, if you were admitted with an event, whether a heart attack or you had a procedure or surgery, you'd have lots of nurses, probably more nurses than you would ever be able to remember their names. And then afterwards, a lot of nursing opportunities in making sure medications are managed, helping with lifestyle changes, for sure in a cardiac rehab program. We're kind of everywhere. We're pretty pretty robust and large group across the nation.
So let me ask you, just to kind of follow on to that question. If I was a patient and you were talking to a lot of folks who are either, as we mentioned, at risk of cardiovascular disease or have suffered an event of some sort, what would you encourage them to lean on nurses specifically for, if they were in a clinic or at a hospital in particular?
Yeah. I think one of the things we learn in nursing school and part of the nursing theory is looking at the whole patient. So, and not that other clinicians don't, but it's the holistic approach is part of our training. And so we look at everything. So sometimes you may feel when you come into the hospital, it's a bunch of tubes and numbers, and our goal is really to say, okay, what really brought you here? How can we help you address certain things like social determinants of health? Do we kind of make these assumptions that people have access to everything? So our job is to break down barriers, remove those things that may create a situation where you can't get access to the things that you need to live your healthiest life and either prevent your first heart attack or secondary heart attack. So that's kind of the social connector. I said, my role was always kind of like the Facebook of patient care. It was to connect all the providers, make sure that everybody was on the same page. I'm not sure I'd use Facebook anymore as my my analogy, but I still think it's connecting and really looking at, if you do have 5 clinicians, how do we make sure we're not giving you different information and navigating the healthcare system. I mean, I think I find it hard to navigate the healthcare system. I find it hard to help my parents navigate the healthcare system. So people who don't have that advocate, it's challenging. We have not made it easy for people when they really need something and need more complicated or just more detailed care.
I love that, the Facebook term there. You have to call it the meta or whatever it is now.
I
it's
know.
More yeah. So let's dive in here a little bit. So one question I wanted to start off with is, we talked about prevention, and I think we make it difficult for folks because there's a lot of terminology in particular around cardiovascular disease and heart health, I think. So can you, I think if you're a patient, you may have heard a doctor or a nurse talk about primary prevention, secondary prevention, tertiary prevention. Can you kind of suss out a little bit what we'll start with primary and secondary prevention, and then you can hit tertiary if you feel like that, if you'd like to.
Yeah, and I think we actually have this conversation a lot amongst our Preventive Cardiovascular Nurses Association, is what level of prevention are we involved in? And it's really all of them. So primary prevention is really preventing a first event. So it's, it starts at birth, and really we're hoping to prevent any sort of cardiovascular event. So this is either by preventing or treating risk factors that increase your risk of having a heart attack or a stroke. So some examples would be eating well, getting regular physical activity, not smoking, or addressing high blood pressure or high cholesterol. So again, it's really before that time that you actually have an event with a heart attack, stroke, and or hospitalized and need a procedure. So secondary prevention naturally follows that. And it's, there's so much we know now compared to, 50, 60 years ago about what we can do to help you prevent the onset of another heart attack or stroke. And so this is really by first treating the disease. So it starts in that acute phase when you're in the hospital. And then really trying to halt or slow the progress, prevent another event from happening, looking at what you may need to address. I've had patients who've come in and are CrossFit champions and, have all kinds of things going right for them. But, you kind of dig and you find out that they're eating a pint of Ben and Jerry's every night. So maybe there's always some opportunity to help with some secondary prevention. So this can be medications, maybe aspirin, cholesterol, blood pressure medications, or getting patients into cardiac rehab programs. And then tertiary prevention is really more when you've kind of entered into that phase where it really is chronic. So you may have, in the cardiovascular world, it may be more like chronic angina, heart failure, a chronic arrhythmia or irregular heartbeat. And that's really looking at kind of day to day, how are we going to manage this day in and day out to keep you out of the hospital, to make sure you have the quality of life that you want, even though you may be taking 8 medications a day or have some physical limitations. So that's also more cardiac stroke rehab programs. And a lot of our tertiary programs really try to make sure that people have the social support, so support groups or kind of long-term classes and people that are around them living with the same condition. Because I, who've never had a cardiac event, can try to coach you and counsel you on living with this disease, but I don't know what it's really like. So those people who are living with it are really the better people to share with you. Again, why I'm happy that Vicki and Lisa will be sharing their story after us.
So, Kim, I think that when, people think about, heart disease prevention, they're generally thinking, eat well, exercise, those kinds of things. But let's say that someone unfortunately has a heart attack or stroke, and now we're talking about secondary prevention. You've mentioned medication there. What in your mind, when you see a patient who suffered an event, how do you explain to them that the game has really changed for them?
Yeah, I think, when we're talking about your chance of having another event. So if we look at just the statistics, right? So about 750,000 Americans have a heart attack every year, but 30% of those are actually a second, third, fourth event. So that's almost a third of those people are having a second event. So it's really real. And I think we throw a lot. You can enter a hospital having a heart attack and leave on 8 new medications and never really had been required to either take medications or make all of these changes. So I think, my conversation is really listening, making sure I understand what they understand, because everyone's level of understanding is going to be different. So that gives me kind of a jumping off point to say, okay, what do we need to talk about? I spend a lot of time on medications because medications are confusing, right? We give beta blockers to people whose blood pressure may have always been normal, or we give cholesterol medications to somebody who's always been within that normal range, and yet they need it now, right? So the numbers don't always tell the story. So we talk about what the medications are for. And I pretty much start off with every medication we're giving you here is for your heart to prevent you from having another heart attack. And don't always read what it says on the side label or the information it says of what it's really for, because that's our goal.
Can I ask you a question, Kim, about adherence? Because you mentioned you have an event, and then all of a sudden, you might have to be on some sort of medication in order to prevent another one. But we see that there's a lot of data out there that shows that we have a lot of problems with adherence. And honestly, we're even dealing with an issue with this right now where patients are switched on medications, a lot by their health plan, or they get a new job, and then all of a sudden, a medication isn't covered that they've been previously on, that a prescriber has prescribed. And, it's hard to stay current. So can you talk a little bit about the importance of that and why it's important to, stay on your therapy? And also, actually, can you touch on the importance of talking to your clinician about these challenges? Because I think that sometimes either people, the out-of-pocket costs can be really high. They're dealing with an insurance company that won't cover the medications, or they're switching them every plan year or whatever. Can you talk about that dialogue and how important that is too, to work with your provider on these things?
Yeah, it's such a great point. I think most people want to please the clinician they're seeing, right? So it's hard for people to admit that they may not take their medications for many reasons. Maybe they forget, it doesn't make them feel good, they can't afford it. So all real challenges. And so I think we need to frame our questions a little bit differently around the medications. I think our electronic health record has taken out some of that requirement for conversation. So we just run down that checklist and say, okay, you're taking X, Y, Z. And they're like, yeah, and they really don't even know what they are for sure. So I think, again, spending a lot of time on those medications. So going through what they're for, asking them questions around how many times this past week were you not able to take your medications for any reason? And then that really can hopefully open up a non emotionally charged conversation around why they couldn't take those medications. I think I was just talking about this with a friend is, I think when you go to a clinician, you assume they know which insurance covers which medication and how much it's actually going to cost you. I will tell you, most of us don't know that, right? Like, especially when you're leaving a hospital, it's really, really hard to figure out how much it's going to cost because there are different things around deductibles and copays. And then, like Ryan mentioned, you said about non-medical switching, your insurance may switch the medication. So again, we make it super challenging for these people. Plus we have generic and brand names, and it can be all confusing. So I think when talking to patients, if they can't pick them up, and this needs to be really emphasized when they leave the hospital, if there is any reason you can't get your medications when you get to the pharmacy, or you pick them up and you're not feeling well, you need to let us know. So that's where like our transition of care clinic really fits in. Also where our cardiac rehab fits in too, because these patients develop these relationships with the clinicians in there, and they can actually kind of feel like they can share, well, gosh, I don't take it that much because it doesn't make me feel better, or my, family member said not to take it. So while we, I admit it, kind of our secret is that we don't know oftentimes what it's going to cost, but we also, on the flip side, know of a lot of tools to help manage that, but we just need to know. So we need to know that you can afford it, right? So we can look for copay cards or patient assistant programs, or if your insurance is denying it and we don't know that, like we need to have some ability to address prior authorization and try to get you the medication. So it's, again, just making sure you're bringing forward what the side effects are, why you're not taking it, giving us that information, and let us figure that piece out, because there's kind of a lot of tricks that we have up our sleeve with our pharmacy friends to get people their medications.
Just gets to the point that how important it is to develop that relationship with your doctors and your nurses. So appreciate that, Kim. So a good question that was dropped in the chat, and actually it's interesting because you kind of spoke to this a minute ago when you said you were talking about tertiary care, and you talked about other support services. So this kind of falls in that category. So someone asked, they said, I had an event and struggled with mental health afterwards. Can you talk about that a little bit? Like do we talk about that more in the cardiovascular space, and what resources are there for that kind of anxiety and that fear that you have after an event like that?
Do we ever talk about mental health enough and openly and honestly? I mean, I think that blanket answer is no. But we know that, at least 1 in 5 patients have depression after a heart attack. And we're seeing it even more with COVID right now. I mean, with social isolation, and the people who are at the greatest risk of getting COVID are those at greatest risk of developing cardiovascular disease, which means social isolation, which means more depression. It is something that has to be addressed. It's not something that's asked by everybody. I think there's definitely a bigger national platform. I mean, you see mental health in athletes, and you see it a lot in kind of the cardiovascular professional organizations as well. I know in cardiac rehab, it's an essential component is mental health. So there's almost every program I've ever been involved with has education specific to that, asks questions. So we use a tool that asks questions to screen for depression. We have a place where we can connect people to hopefully get them in to talk to, therapists. But a lot of times it's the depression or anxiety around it is helped through being in support groups, whether online or in person, and in some of these programs. But definitely a huge opportunity. I think people are trying to automate it a bit more and put it into required screening in like an electronic health record, which is great, because we have to talk about that. Just like your meds, we need to say, kind of mentally, do you have the support and, to do what you need? Just like we would say physically, do you have the support through a walker or someone who can help you take care of kind of your daily activities?
I guess the takeaway point, though, is if you're feeling that way, you're not alone. I mean, you said 1 in 5.
Yeah.
That's
Yeah.
incredible.
Yeah. Yeah. And I think, again, the stigma is tough, right? I mean, I think people come into relationships with the clinicians, and we need to make sure the people coming to us feel comfortable to share that. And if we don't ask about it, then we're basically stigmatizing it, because then it's not even a topic that's brought on the table. So we need to bring it forward, probably not just one time, but multiple times, to really make sure that, because the first time I meet someone, I'm sure they don't want to bare their soul and tell me about all their problems, but
Yeah.
by appointment 2 or 5, they usually do.
Yeah, absolutely. So you mentioned in a prior response about these fit CrossFitters that you might see, or a football player that might have a heart issue. So I want to actually kind of dig into that a little bit. So let's talk about the folks who you see on the street, and they're like they look like picture perfect, embodiment of health. They're young and fit, and you'd never think that they would have a heart attack. And we talk to folks like this all the time, frankly, who you see them and you're like, you're 32 years old and you run 3 miles a day. Like, what's going on? But one day while doing a 50-mile bike ride or a run, they find themselves in a hospital after suffering a major heart attack. So I guess what I want to talk to you a little bit about is, can you talk to us? And I think it's something folks don't think about. They're thinking about it more, but this has not been the case in the past, about the genetic or inherited component to heart disease. Can you speak to family
Yeah.
history and the genetic component a little bit?
Yeah, absolutely. So, if you have a family history of an early cardiac event, it is a significant risk factor, and it shouldn't be ignored. I think what I hear and see a lot is, I personally live a much healthier life than my, father, or he wasn't healthy at all, and I do everything right. And then you say, well, what was your cholesterol? And they kind of hem and haw, and they say, oh, well, it's 350, right? And you're like, oh, well, okay. So you are doing everything, but sometimes genetics are very strong. Ask my redheaded daughter, who is studying genetics right now. She will tell you it's strong. But I think what we're talking about when we're talking about family history, so the definition is a first-degree male relative, so a father or a brother who's a blood relative who had a heart attack by age 55, or a first-degree female relative, mother or sister, who had a heart attack by age 65. So I think sometimes we just brush through that question and we say family history and we assume people know what that means. But I think you really need to outline that piece, because I think then that helps them figure that out. And if they say, well, I don't know if they had a heart attack, but they passed away at 50, you can start making some assumptions that that if they had an unexpected cause that led to their death, then you need to be talking about that. So genetics are strong. You can't pick your mom and your dad. And so I know you can't change that piece, but I think denial is really strong too, right? Like talking about is, I know I'm at risk, but I do everything I can. But I think oftentimes, like when you start digging, there are always things. I think if somebody went and started asking me about my risk factors, they'd even find opportunities as well.
So a question, Kim, that's related to someone dropped in the chat is, should I get my kids screened for high cholesterol? Is that a thing? Does that happen now? Or like, is it a standard that we screen children for cholesterol, or should folks ask about it?
Yeah, absolutely. I mean, especially if you're on cholesterol medication, to get a baseline, and it kind of depends on when you first identified your high cholesterol. But I mean, it doesn't hurt to get that baseline, because I mean, we do a lot as parents. Again, I have two teenage daughters, right? And so you're on the go, you're going really fast, you feed them food that's convenient. But kids with high cholesterol in those really formative years, you start laying down plaque early. I mean, we know that from looking at pathology as in slides, and looking at young people who've passed away, is you start to lay down plaque early. And so if you are doing that and you don't even have high cholesterol, imagine what happens with kids who have high cholesterol. So if if your cholesterol is totally fine and no one in your family has high cholesterol, probably not. They'd push you off until kind of their early teen years. But definitely, again, it goes in line with that being your own patient advocate and your own family advocate, because it doesn't cost us that much as a healthcare system to know. But if you know 10 years earlier, imagine the changes you can make when they're developing such crucial habits for their life.
Kim, can I ask you, and I know this is probably a loaded question. I imagine someone would probably ask it. This is going to be one of those questions that I think someone would be like, "Oh, I was going to ask that question." What is a normal level for cholesterol?
Normal level for like total
For
cholesterol?
LDL? Yeah.
Yeah, for LDL. Yeah. So, I mean, ideally, we'd love to see everybody below 100, but the normal on labs that you'll see is less than 130 for LDL.
Okay.
Well, we'd like to see everybody lower than that. Once we've seen them for a heart attack, we want everybody kind of below 70, but but yeah, 130.
Can you touch real quickly on familial hypercholesterolemia? What it is?
Yeah. So you asked about kind of the genetic piece, and I don't personally work in a lipid clinic, and so there are programs around that deal with this where families either have, people have two of the genes that cause those individuals to have high cholesterol. So if you have one gene which causes this FH or familial hypercholesterolemia, you will see high levels of cholesterol. You could see, LDLs above 200, 300. But once you get both of those genes together and you're homozygous, which means you have both parents gave you a gene, you're starting to see total cholesterol levels, above 1,000 and above. And it's really, it's very strongly genetic and needs to be identified early. And that's where you start to see, once that's identified, that's really where you're more likely to get your kid tested and early on, because they'll do what's called like cascade testing, where they look at they look at all the family members and start to test everybody just to make sure they catch it early.
Thanks, Kim. I appreciate that. I just wanted to make the point that folks know that there's actually a genetic, condition here. So,
Yeah.
Two more questions, and we've just got a couple minutes left. But you've touched on this a couple times, and I know you've spent part of your career working here. So, can you give us a glimpse of the importance of what cardiac rehab is, and the importance for engaging with cardiac rehab, especially if you've had an event?
Yeah, absolutely. So this is near and dear to my heart. I've been involved in cardiac rehab since I was actually volunteered in high school and then kind of beyond there. So it's actually a medically supervised team-based secondary prevention program. So after an event, the goal is really to improve heart health, but it's also been shown to improve muscle strength, and kind of to that point of around mental health, absolutely has been proven to help individuals kind of recover from depression and manage some of the anxiety and stress that was either before the event or subsequent to the heart attack. So it's fantastic. I feel like you kind of get wrapped in this blanket of clinician support. It's such a passionate group. It usually has dietitians, exercise physiologists, nurses, and physicians, and oftentimes a social worker to help address all the risk factors. So usually 36 sessions. It's covered by Medicare and most commercial insurance programs. And so when you talk about somebody having a heart attack, and you think about like, what does everybody get after a heart attack, right? Like you get your statin, then you get your baby aspirin, because it's been so strongly proven that it helps reduce the risk of another heart attack or even death from another event. Cardiac rehab is right in that same level of recommendation. We call it a class 1A, which you can't get any higher. And so because it's been shown to reduce the risk of death by 20% over about 1 to 3 years, and about a 30% reduction in rehospitalizations over a year. So it increases physical function, increases quality of life, ability for people to be independent for longer. And this isn't just for people who've had heart attacks. It's covered for people who have heart failure with a reduced ejection fraction, people who've had valve surgery, bypass surgery, and there's some other conditions as well. So it's like a built-in support group with a really safe environment to gain confidence getting back into exercising. We've had 20-year-olds with heart transplants sitting next to 93-year-olds who on their fifth heart attack, and the information and support they glean from one another is truly heartwarming.
Absolutely, that's great. So, Kim, final question for you. Just wanted to get your thoughts. Something that unfortunately continues to dominate the news. I just want to talk real quickly about COVID. We saw that early on in the pandemic, prior to vaccines, that individuals with diabetes or cardiovascular disease were particularly at risk for complications due to COVID. Now that the vaccines are available, can you shed any light on what you're seeing in terms of outcomes for cardiovascular patients, and maybe the breakdown that you're seeing in hospital systems around you, that kind of thing?
Yeah, absolutely. So I think there's a lot of questions around COVID, and I think everybody wishes COVID wasn't at the top of our minds right now. We are super thankful for the vaccine. Large medical associations across the world are recommending it for everybody, especially those at risk, and that's because the data is very strong. So you look at the two kind of questions we receive are from people who say, okay, am I at risk for a cardiovascular event? We're seeing, is the vaccine going to lead to an actual event that I, didn't know? And there was a study published in July, and it was from the World Health Organization database, and they looked very closely at the number of cardiovascular events that occurred after a vaccine, and there's no causality that's been established. That's because those cardiovascular events that occurred after people got the vaccine were associated on the same level as the general public. Then the other question is if I have cardiovascular disease, should I get a vaccine, and how does that help? Again, there's going to be more data and more studies coming out of COVID on all levels for years to come. But what we have seen so far is that there's a similar efficacy and safety. So for individuals with cardiovascular disease, diabetes, other conditions, it's the same safety and effectiveness as those without those conditions. And so, what we're seeing in the hospital is we're seeing, still about 90% of those individuals in with COVID now are unvaccinated, and almost 100% requiring intubation and needing to be in our critical care units for 3 weeks are those individuals who were not vaccinated. So, and those, those who don't make it from the ICU often have some of these cardiovascular conditions. So it definitely reduces the risk. It helps prevent hospitalization, helps prevent spreading, and then hopefully keeps you going so you can come to our cardiac rehab program still.
Well, Kim, that's all the time we have. But I mentioned at the top that we enjoy working with the leading lights in cardiovascular medicine. You're definitely one of those people, and we appreciate all the time that you give to Patch. And it's always a pleasure to talk to you. So thank you so much for joining us, and thanks for letting us pick your brain here for 27 minutes.
Thanks for having me.
So, Kim is just great. We just love working with her. I'm now going to introduce to the screen Olivia Medina. Olivia works with us at Patch and will be leading the conversation that we will have now with a couple of patient advocates. Olivia?
Thanks, Ryan. Hi, everyone. My name is Olivia Medina. Like Ryan said, I'm with the Partnership to Advance Cardiovascular Health, also known as Patch, as we like to call it. We are so excited tonight to be joined by two heart patients who reside in California, Vicki Soll and Lisa Ferguson. Both Lisa and Vicki have experienced some form of heart disease firsthand and now are dedicated and passionate patient advocates. Vicki and Lisa, welcome. Thank you both so much for joining us tonight. It's so important for people to hear from patients like you, hear the live experience. So thank you so much for joining us. And like I said, your unique stories and discoveries are extremely valuable to our audience and to the general public. So that's really what's going to be driving this webinar tonight. So with that, I would love to get started. Can you each both start off by just sort of level setting for the audience. Can you just tell us about yourself, your family, where you live, and how you spend your free time? Vicki, I'll start with you.
Sure. Hi, everyone. Good afternoon. I am here in San Jose, California, right in the heart of Silicon Valley. I'm a very active, very fit person. I do a lot of running, swimming, biking, love being outdoors. Always had a good diet, always maintained my weight. I live here with my husband. I have a great support team around me, which I think helped when I had my event. And as Olivia mentioned, I'm very involved in the Women Heart organization, which I'll be happy to talk about later.
Definitely. Thank you so much, Vicki, for that. And Lisa, how about yourself?
Hello, I live in San Diego, and although I moved about 23 times in my life, only 3 of those were outside of San Diego, so I know the area really well. I have 2 young adult children in college, and I live with my husband. We have not quite launched the kids yet, but almost. In my free time, I'm a yarn and thread crafter. So I love anything involving needles.
That's wonderful. Thank you both for sharing so much. And I think especially I want to definitely get your women's perspective because like you guys mentioned, you're both from the Women Heart Organization, which is a great advocacy organization for heart patients like yourselves. And I think we haven't had that women perspective. So I'm excited to dive a little deeper in that. So thank you both for sharing that. But now I want to also level set for the audience. But can you guys each take us back to the day or sort of, I guess, time period where you realized something was wrong and when you guys had your event? Can you just explain that for the audience, please? Lisa, I'll start with you.
Sure. So so just to clarify, I have a mitral valve disease. And so my event was that I had open heart surgery back in 2016. So when I was pregnant about 25 years ago, I was told that I had a heart murmur because they're easier to hear when you're pregnant. You have an increased blood volume. And like most people, I think, I was told that it's very common, nothing to worry about. And believe me, when you're having your first child, when the doctor says you don't have to worry about something, you don't. It gets filed in the back of your head. So, but what's interesting is that even when my dad had the same surgery that I ended up having, his was about 7 years before mine, I really didn't connect it to my murmur. Years later, I asked my primary for an echo as a, kind of follow-up to see how things were. And she said no, because she didn't hear anything wrong. So it was intuition. When I just knew that there was something wrong. I knew it was time for me to be checked. So it finally took a visit to the ER because of chest pain to just get the schedule, an echo ordered for me. But because, again, they didn't think it was urgent, it took 3 months for me to actually have the test. And what's crazy is that whole time I was already in heart failure.
Wow. No, I mean, that is just, unfortunately, it is common. I feel like we hear people's stories and like you said, your intuition, you knew something was wrong and you sort of pushed back and got that test, but that's not always the case for everyone. So we'll have to dive.
And it's not, I was going to say it's not always affordable too, because those kind of tests can be expensive.
Yes.
I know, Kim was talking about the expense and the availability, accessibility to things. So, that certainly plays into it as well,
No, I agree, definitely. And we'll dive into accessibility in a little bit, but I want to hear about Vicki. I want to hear your experience with that and how that came about.
Sure. Well, unlike Lisa, I was always very healthy. I've never had any heart issues at all. Interestingly enough, I did have high blood pressure that I was taking medication for probably since I was 21. I inherited that from my father's side of the family. And I always had cholesterol that was on the high side of normal, but again, it was always being watched. And other than that, I was just, living my life. When I was 53, this was 9 years ago, I had a heart attack. I was in a waiting room waiting for a massage. I was filling out a form, or I started to fill out a form. And then I just felt this incredible burning in my chest that shot up through my neck, my jaw, ping pong through my shoulder blades. I had never experienced anything like that before. There was no shortness of breath, no difficulty breathing. It was just this unbearable burning sensation. And of course, I did have that shooting pain down my left arm. And so I was taken to the ER. And because I was a woman, youngish, physically fit, non-drinker, non-smoker, I didn't fit the profile, and they did some blood work. They gave me some morphine, and they sent me on my way. I was told to visit my cardiologist, and so I did the next day or two. And when I failed my stress test, that's when she sent me immediately to the ER. And this second visit is when they did more blood work, and it was discovered that I had had a heart attack. I went to the cath lab, and I was diagnosed with something called SCAD, which is spontaneous coronary artery dissection. And it's the SCAD that actually caused my heart attack. And for those of you who don't know what SCAD is, what happens is the lining of your artery, somehow there is a tear that develops, and then the blood that's flowing through your artery gets caught behind that tear, and it starts pushing the flap of your artery into the artery itself. And that's what causes the blockage. So for me, that's what caused my heart attack. But I was fortunate enough, being here, talk about accessibility. I'm in Silicon Valley. I have the best, healthcare available to me. So I was fortunate. I received a great diagnosis, at least my second time around, and I received, just superior healthcare. So I was one of the lucky ones. But being a woman, there are a lot of women out there who also have SCAD who were not as lucky as I was.
No, I know. Like you said, unfortunately, that is all too common. And I want to dive deeper on the women and sort of diagnosis part of that. So, Lisa, you had said it taken around 3 months to get a diagnosis. Is that correct?
3 months for me to get in to have the test. Yes, right. The diagnosis happened immediately.
Okay, immediately. And then Vicki, what about yourself? How long did it take for you to get a diagnosis?
It took about 4 days, because in between my visits to the ER, so I was walking around blocked arteries for 4 days.
I mean, both of you just have, thank God you guys are still here with us today and healthy, but I feel like had you guys waited a little bit longer, you might not be in that same position. So I want to sort of ask about that. So you guys both have sort of had, a convoluted process to getting the right care, getting the tests that you needed, getting the treatment that you needed. So can you guys sort of expand each in your own experience, how you went about sort of advocating for yourself and how you went about pushing, like, I need that test. I know something is wrong with me. Do you have any, advice or any best practices for that? Because I think that's a huge struggle in cardiovascular medicine as it is, just advocating for yourself when you know something is wrong. Let's say, Vicki, you want to start with us?
Sure, I'd be happy to. In my instance, when I was taking my stress test at the cardiologist, and I just stopped when I was in pain after about 3 minutes. And I just told, the staff person, I said, I'm in pain and something is wrong. So that was how I started to advocate for myself. I didn't have to do much because my cardiologist immediately threw me into the ER and they took over from there. But I will say, hearing other women's stories, I can't tell you how many times I've heard the story where people didn't believe me. The doctor just said, "Oh, you have digestion." And that's actually when I was in the ambulance. They're like, "Are you sure you're not, you don't have heartburn?" And I said, "No, this is not heartburn." And so sometimes you need to trust what you know and just really stand up and say, something is wrong. And, I've learned over my events that you need to use the right terms. You need to say, "I am in pain. I believe I'm having a heart attack," because as women, we tend to say things like, "I have some discomfort in my chest," or "My back is bothering me." And then people just go, yeah, you have, indigestion, or you pulled a muscle. So people, especially women, we describe pain differently, and you just need to stand up and really explicitly say what you think is wrong.
No, that's so helpful. I think especially when we think of women in the healthcare field, you sort of touched on it, but people might just think you're over exaggerating, or you don't know what you're talking about, and they know better, and you're trying to tell them, "No, I know better. I know my body." So that's a very interesting point. And Lisa, how about yourself? Did you have any advice or best practices for advocating on behalf of yourself?
Yeah, so I mean, it's interesting that because when I learned Vicky's story, it was interesting that we both shared the same diagnostic test, ultimately a stress test, which for me was a stress echo, where they combine the echo with the stress test. So I also walked on a treadmill, but they did essentially they took images of my heart before and after to see what was going on. And so you don't know. The end result, I think, is that test, explained a lot to our doctors. Why it was just one test, changed our worlds, and for me, because I was told my stress test was interrupted, and the doctor came in and asked if I was okay. So I knew something was really wrong. And like I said, it was less than 24 hours later when I knew that I was in heart failure. But I'm an inquisitive person by nature, and I'm pretty good at being persistent, which is not a simple thing to do when you're sitting in an exam room and the doctor comes in and they're trying to explain something to you that's life-changing, and you don't know what you don't know, right, at that point.
Right.
And it's likely that you're going to go home and you're going to Google, you're going to talk to friends. So my advice is that you really, really need a trusted medical professional on your side to turn to. And it's not easy either. That's not easy either when you're in the middle of a crisis. But a doctor that you trust and and that allows you follow-up questions, because the process of absorbing what's happening to you takes some time, and you need that access to be able to go back and ask questions of the right person. In fact, the doctor that came into my stress test, who was the one I saw initially, he laughed at some of my questions in that first meeting. So, I didn't have any problem firing him and finding someone new, because it really is worth the effort, to find somebody that you click with, that you're going to trust their advice. So I think that's the most important thing you can do.
Absolutely. And I think especially Ryan and Kim sort of touched on that too, how valuable that patient-physician relationship is, because to both of your points, you need someone in your corner that's going to be with you and advocating with you, and not sort of dismissing your scary thoughts. You guys both just experienced crazy cardiac events, and you have someone telling you that, "Oh, it's not that bad. That's okay." So you both kind of touched on my next question, and this also relates to a question that we have from the audience that I want to get to. So it says, and you guys both kind of answer this, so we can just expand. But it says, hearing that you talked about the pain that you felt and feeling dismissed since you were a healthy woman, do you feel that women have a more difficult time getting care? And I'll sort of add a caveat to that. What would you say a woman in your same position, you guys are both a part of Women Heart who are supporting women and going through the same things, what is sort of your slogan or tagline of advice for someone going through this event? Whoever wants to take that one.
I'll be happy to talk to that. I would just say my slogan is trust yourself, trust your knowledge. If you think something is wrong, then it's wrong. And most definitely, especially from the stories that I've heard with Women Heart groups, so many women do not get the diagnoses and the care that they need, even just being prescribed aspirin. They just were so easily dismissed by the medical profession. And honestly, even when it comes to clinical studies, women are in a minority. Women, and especially people of color, are in the minority. Up until just really fairly recently, so many medical clinical studies about heart disease were done mostly on, white males. So women respond differently to medications than men do. We're different size. We have, hormones. But, at any rate, women definitely have to fight to get the, equal treatment when it comes to medical diagnoses and treatments. And you just need to trust yourself. As I said, if you think something's wrong, then it's wrong. Don't second guess yourself.
Yeah, and I'll add to what Vicki's saying in that we have support groups that we run throughout the nation. And in San Diego, we run 3 here, and Vicki is one in the northern part of California. So honestly, I've heard a lot of stories, and that's exactly it's true. What she says is that I'd say 80% of women that come in and tell their story start out with, yeah, they sent me home. I went to the emergency room and they just told me I was having a panic attack and sent me home. And in the meantime, they were either having a heart attack or about to have one. So, it's really distressingly common. But again, I think Kim also touched on this, where you want to, you kind of revere the medical community. And if a doctor in an emergency room is telling you that, it's hard to push back. But that's where the education part comes in. That's where like doing what work we would do with Women Heart, volunteering to kind of just share stories. It ultimately, the goal is to help other women know that, I remember, a woman telling her story, that how she got pushback, and to not accept it. It's your body, and exactly what Vicki was saying. It's like, trust yourself.
Trust yourself is a great slogan, I too think, just because, like you guys said, you guys were in heart failure and you guys were still getting told that nothing was wrong. That could not be well said. That trust yourself, I think, should be the takeaway from this for sure. But you guys sort of also leaned into my next question, and that is sort of about the resources and support that you guys had going through this, because obviously, as Kim and Ryan touched on, not only are you physically hurt, but you're probably mentally hurt as well. And you're probably going through a lot of different emotions, processing a lot of different things on new treatments and trying to navigate all of that. And that's not all straightforward. So did you guys have you're both a part of Women Heart, which for those of you guys don't know is a great support group and resource group for women, obviously, who have just had a cardiac event. But outside of Women Heart, before you found Women Heart, how did you find sort of the trusted resources, the trusted people you could talk to really support you during this time? Any advice there?
I'll say that I'm very lucky that I have a cardiac nurse who's my neighbor. She lives next door. Having somebody that does heart surgery, she's in the operating room, telling me her experiences and her giving me her support. And luckily, I'm not a faint of heart person, and I don't mind the gore and all the stories that she had to tell. because in a way it really helped me. That's the way I process it. And I think that's the challenge, is finding a resource that, whether it be a person or something you're reading, that makes you feel supported, that kind of addresses the mental battle that you're going to be facing. Because I think that's very important. And in my case, my valve repair did not last. So even though some of my issues, I'm not in heart failure anymore, but I still have severe regurgitation. So I need to have resources continually. I need my doctor to be in my life, and to be able to ask questions. And I have echoes still regularly, and understanding what those things can give you, and what they can tell a doctor. Because the one other thing that I find very interesting, I don't know, Vicki, if this is the case for you, but my cardiologist always wants to know how I'm feeling, because that's the most important sign for them, is that, if you're feeling good, that counts for actually the most. It really does. Because, yeah.
Right. Vicki, I'm curious to hear your perspective. Any advice there?
Yeah, I mean, for me, I would say it's cardiac rehab was just a lifesaver, because having exercise be, physical fitness be such an important role in my life. After having a heart attack, I was just petrified that I would not be able to go back to exercising. I was just thinking, so what if I run again? Will I have another heart attack and die? I had no idea how to even approach incorporating or going back to exercise. And with cardiac rehab, not only were the nurses there amazing human beings, but I really felt that being monitored, that closely monitored, I felt more comfortable slowly getting back into exercising until I could get back to my normal routine. And as part of cardiac rehab, it's not just about the exercise, but they also hold free classes about stress, nutrition, medication, so many other things as well. And that's where I got to ask a lot of my questions too, because in the beginning, I'd never had a heart attack. I'd never had heart disease. I had no idea what was going on. So having that support with cardiac rehab was just immensely helpful. And I will say, I had a great cardiologist. I had a female cardiologist, and she was the one who actually suggested that I start the support group, that I, go see the support group, which I pushed back on for a couple of months. I thought, oh, I'm fine. I don't need this. But once I started attending the support group meetings, I realized I should have done this from the very beginning, because you have these other women who've gone through traumatic events, and they know what it's like to be scared and not know if they're going to wake up the next morning. So the combination of those two, I would say cardiac support, cardiac rehab, a great cardiologist who listened to me, and also, of course, the Women Heart Support Group.
No,
and I will add, can I add one thing?
Of course, please.
That so I feel the same way. I went through rehab. It was critically important, but that's the dilemma. A woman in a typical cardiac rehab setting, you're going to be the only person under 80. At least that was my experience. And mostly, it was 90% men. So that wasn't where I found support. That was, it was the mental thing of being able to exercise and see myself recover. But the support, that the other part is finding a woman who's been dealing with something that's similar to you, is where the support group became really critical. So.
No, I think that's a great point. I think you seeing yourself sort of after the fact and knowing you were just as strong as you were prior to the heart attack, and the heart attack or cardiac event doesn't define you. And you guys, I think, are great examples and advocates, so other women can know that it's a possibility and know that they're not, their trajectory is not made by this event. So thank you both for sharing that experience. I want to ask a final question for you guys. So you both didn't know what was going on, prior to your event. And heart disease is obviously something to be taken seriously, both on the prevention and management side of things. So, how have you guys found the most helpful to staying adherent to either your medication or treatment regimen, but also remaining positive on this is something you kind of have to take into consideration for, the indefinite future. So, would love any advice or tips there. Whoever wants to go. Vicki, I'll start with you.
Sure. I think for me, when you first have a heart attack for that first year, they put you on this little cocktail of about 4 or 5 different medications, but then they wean you off of it. So for the rest of my life, I take 2 medications, one statins and one for my blood pressure. And I've just come to accept that. This is my life. This is what keeps me alive. And I'm a very compliant person, so I don't have issues taking medications to keep me alive. I pushed back a little bit at first. I said, I have to take this forever. They're like, yes, this is just how it is. Also with the statins, I had something called restenosis. So my original set of stents failed because I was resistant to my blood thinners. So I had some additional stents put in, but once I understood that it was the statins that were going to help keep me alive, I just accepted that. And I've had no problem taking my medications. I've been weaned down and I only take 2 plus an aspirin. So for me, it's what I do and I'm fine with that.
No, that's good advice. I think the trade-off of taking medication versus a life or death event is definitely worth the medication. Lisa, how about yourself? Any advice on staying positive and staying adherent?
Yeah, I mean, for me, it's a little different because I'm kind of in this holding pattern. I have no control over my regurgitation getting worse or my heart muscles getting worse. So my heart health is a priority, which it would be, when you kind of know there's something brewing. And so I'm going to go back to what Kim said. She was talking about having patients understand why they're taking medications and what they do. And that has been a really a big part of why I've been adherent, because I know why I'm taking aspirin. I know why I'm taking a beta blocker. And those are my 2. I only take 2 medications as well. But it's part of is, going off a medication that you don't need, questioning medication. Those are all important things to do. Again, with your trusted doctor, understanding why you were prescribed something and why you're taking it and how it works. A lot of times the medications are off label. And that is, again, you can't go home and Google it. You've got to trust that it's needed for the reason that it's being given to you. I mean, it's just really odd to have something wrong with you in a part of your body that you can't see, or anyone else can see it for that matter. You can't watch it heal, or you can't know that it's getting better necessarily. So for me, the concentrating on what's above your, the part of your body above your shoulders is a really important thing. Your thoughts, your experiences, what you take in, what you share are all the things you do have control over. So I think that's a really important part of staying sane.
No, I think that was very well said, of just focusing on things that you can control, and the things that you can't control, ask those questions, find a provider who will take you seriously and who will work with you to find the treatment plan that's right for you. So that was both great advice. I think trust your intuition is the huge takeaway from this. And you guys have both been great advocates that we so appreciate you guys both sharing your personal stories. But unfortunately, with that, we are out of time. So I want to thank you both for joining us, sharing your stories, and honestly, just expanding the public awareness for cardiovascular disease, but especially for women. So we appreciate you guys so much. Thank you.
You're so welcome.
Thank you. Thank you.
All right. So with that, guys, I just want to say thank you so much to all of our speakers and my colleague, Ryan, Kim, Vicki, and Lisa. You guys were amazing, so thoughtful and so insightful. Patch's mission is really about helping people. So if you are aligned with our mission, if you are a clinician, patient advocacy organization, or an individual living with heart disease, like our patients here today, and interested in sharing your story, we are more than welcome. We are more than happy to welcome you to Patch. Our membership is free, and you are always welcome to collaborate with us. On this next slide, you will see all the ways to connect with us. And I just want to say thank you to everyone who tuned in this evening. I hope this was informative and helpful for you, and we'll see you again soon. Be well.